Thank you, Mr. Chairman. So after this nice introduction, it's my task to talk about genetic predisposition and opportunities for early detection. The question, of course, at hand is how we can improve pancreatic cancer survival, because we have seen the dismal figures of the past decades with regard to outcome in pancreatic cancer patients. And first and foremost, we have to improve the access of patients to the appropriate healthcare resources throughout the world, but also in Europe. This is still a problem. Not all patients get good healthcare in Europe. Secondly, of course, we have to develop more effective new adjuvant treatment modalities. One of the things I think the surgeons have done their work. They have really mastered the operation, have tried everything with regard to improving outcome, dissecting lymph nodes whatsoever. They have done their job. Now it's the job for others to complete the effectiveness of treatment with effective neoadjuvant therapies, including immunotherapies. And there are some nice studies ongoing now in the world, and looking forward to the outcomes. We've heard something about primary prevention. We have identified some of the risk factors, and we have seen what the actual risk is. The problem, of course, is that it's very difficult to modulate these. If in a family a person has pancreatic cancer, has lung cancer, in all probability other family members will stop smoking for maybe a few months or a year, but after 5 years' time, if you look back, people have started smoking again. It's very difficult to modify these factors. And of course, we can do secondary prevention, and that's been also alluded to. You can try to identify high-risk populations where you then do screening or surveillance investigations in the hope to detect pancreatic cancer at an early stage. If we talk about genetic risk factors, it is thought that about 5 to 10% of pancreatic cancer, genetic risk factors play an important role, so a very evident role. This is in all probability a huge underestimation of the effect of genetics. And to kind of allude to that, it's good to take a look at the following graph. Because here you can see that if you have a genetic variant, there is a relation between the effect size of that variant and its frequency. Do I have a pointer? If you take in consideration an allele that is very common, very often the effect size is low. So that means for that allele in a patient then finally to arise, for example, to pancreatic cancer, much more factors have to be into play, more gene mutations and, for example, environmental factors. However, in very rare gene mutations, we see that the effect size is often very high, in particular in the rare alleles causing Mendelian disease. So in these specific instances, in all probability, you don't need many additional gene mutations or not that many environmental factors in order to rise to a certain condition, for example, pancreatic cancer. Now, if we talk about hereditary cancer, we have two types of hereditary cancer. First, we have familial pancreatic cancer, and in fact, this is the largest group of persons affected. And why is this a separate group? Because we just don't know the gene that is involved in these families or in these persons. So we talk about familial pancreatic cancer if more than two persons, at least one a family member, the first degree, is affected, or more than 3 persons. And if you look at the pedigree of such a family, you see you have a clear-cut instant view of the fact that pancreatic cancer is very prevalent in that family and that it is an issue. So we don't know the gene, we don't know exactly what the associated cancers are, and also the age at which the cancer arises in this family is very different between families. And what you often see, if you look through the generations, you see an effect what we call genetic anticipation. So in every next generation, the pancreatic cancer starts at a younger age. If you look at the relative risk of these families, of persons from these families to get pancreatic cancer, you can see overall the relative risk is 6.8, but depending upon the number of family members affected, this risk rises quite rapidly. And if you have 3 or more first-degree relatives with pancreatic cancer, it's 17.0. Very important to understand in these families, because we see many of these families and we counsel them, is that if you think about screening, you don't know exactly what you screen, in the sense that you don't know the gene that is affected, so we cannot select the persons to screen based upon the gene mutation. So you end up screening the whole family. And if you talk about a somatic mutation, autosomal dominant inheritance pattern, you know that at least you screen 50% of the family members for nothing, because they will not have the gene mutation, but you don't know which gene. So that's a big issue. That is opposite to another group of families and persons where we have the cancer susceptibility syndromes, where we know the gene, and there are quite a few. The first and one of the most important ones is the familial atypical multiple mole melanoma syndrome, FAM, the CDKN2A gene. And what you see in these syndromes very often is that pancreatic cancer is not the most prevalent cancer in these families. There's an other cancer that is most prevalent, and in this specific syndrome, it's melanoma. But with regard to the pancreatic cancer risk, the relative risk in these persons affected by that gene mutation is between 13 and 39, with a lifetime risk of about 70% up to the age of 75. There's another susceptibility syndrome, the familial breast and ovarian cancer syndrome, where you have two mutations. The first is BRCA1. Most prevalent cancer is breast cancer. And with regard to pancreatic cancer, you can see there is a modest increased risk with a relative risk of 2 and a lifetime risk estimated to be 2.16. To be honest, if you look at all the numbers in these different syndromes, the scientific materials that we have, the source materials, are rather scarce and limited. So there's a lot of work to be done to get to better estimations of these risks, but this is what we have. For BRCA2, the most prevalent cancer is ovarian cancer, and here you see that there is a higher relative risk between 3 and 9, and lifetime risk is estimated to be 3.36. And from my own experience, because we see a lot of these families, you have these typical families where in the BRCA2 mutations there is a prevalence of pancreatic cancer and there's no prevalence of pancreatic cancer. And the families where you have pancreatic cancer, the risk is higher. Familial adenomatous polyposis, FAP, the APC gene, of course, colon cancer is the most prevalent cancer. Relative risk for pancreatic cancer is 5. The Lynch syndrome, different various mutations, colon cancer, endometrial cancer. Relative risk for pancreatic cancer between 9 and 11, with this as the estimate lifetime risk up to about 6% up to the age of 80. This is one of the most important ones, the Poet-Jäger syndrome, the STK11 or LKB1 gene mutation, many different gastrointestinal cancers, breast cancer, but the relative risk, and here we have quite good data now, is up to 132. So this is a hugely increased risk of getting pancreatic cancer, with a lifetime risk somewhere between 11 and 32%. So that's a substantial risk. A very interesting syndrome, Li-Fraumni syndrome with P53 mutations, many different types of tumors, also pancreatic cancer. Relative risk about 7. ATM, ataxia telangiectasia, the ATM mutation, all kinds of cancers. Pancreatic cancer 3. And the PALB2 kind of recently reported as a gene involved in pancreatic cancer, breast cancer, pancreatic cancer, but we are still awaiting the final results with regard to the relative risk. And already alluded to, very important, hereditary pancreatitis, where we know the gene, PRSS1, pancreas, of course, 58, huge spread, but a hugely increased risk, up to 30–40%. And again, if then you come back to other environmental risk factors like smoking, we know that in this population, if people smoke, the risk kind of doubles. So then you can imagine what your lifetime risk for attracting pancreatic cancer is. Now, of course, the ultimate goal in pancreatic cancer detection or surveillance is that you would like to detect an early asymptomatic, potentially curable malignancy, because we all know in a majority of cases, 99% of the cases, people present with symptoms, and if they have symptoms, they already have advanced cancer, and we know that we cannot do that much for them with regard to cure. But we also know if in the odd likelihood that a patient has a very small cancer detected for whatever reason, and it's still a T1 cancer, then the prospects for survival are still not that good, but at least much better than when you have a T3 cancer. It's about 30%. So that already would be some kind of a gain that we could make. But it would be much better even if we could detect a precursor lesion. The same like we do with colon cancer screening. Of course, we screen. We hope to find early colonic cancer, but it would be better, and it is better, to see a colonic polyp, to remove it, and thereby decrease the colon cancer risk. Exactly the same should hold true for pancreatic cancer. Now the question is, like colon cancer, do we have also these precursor lesions in pancreatic cancer? And yes, we have. There are precursor lesions also in pancreatic cancer. One of the best known, of course, is pancreatic intraepithelial neoplasia, a Panin lesion. I will come back to it a little bit later. We have intrapancreatic mucinous neoplasia as a lesion that is important as a precursor lesion for pancreatic cancer. And we have mucinous cyst adenoma. Now, if you, again, take a step back and think now about the subject that we are talking about, high-risk persons, then it's these two that are quite prevalent in these groups of persons or patients. For example, in our study that's ongoing now for many years, where we screen these persons, the prevalence of intrapancreatic mucinous neoplasia is about 30 to 35% in these individuals. That's very high, I can tell you, because the prevalence of cystic lesions in the pancreas in the whole population is about 2 to 2.5%. The prevalence of pancreatic intraepithelial neoplasia has been investigated because persons with a high risk that were operated for pancreatic cancer were compared to sporadic pancreatic cancer cases. And there you see that the number of these lesions, but also the grade of these lesions, are much higher in patients or in patients with a high risk of pancreatic cancer. So these two are important with regard to the risk profile in persons with a high risk for pancreatic cancer. Now for IPMN, what you see here is the progression model, and this looks a lot like what Bert Vogelstein has learned us with the adenoma carcinoma sequence in colon cancer. You have a normal duct, and you have at the end of the spectrum infiltrating cancer. And in between you have these different stages of dysplasia that we call Panin-1, Panin-2, and Panin-3. And I'm not a pathologist, but for the pathologist this is recognizable because this is mucinous hyperplasia, here you have papillary projections, and also the nuclei are a little bit enlarged. And in Panin type 3, there's a complete loss of architecture of the cell, and the polarity is lost, and finally you have an infiltrating cancer. And this is accompanied by all kinds of gene mutations. And in particular, in Panin type lesions, the KRAS mutation is quite early, whereas the P53 and the SMAP4 mutation is relatively late. Now for the interpapillary mucinous neoplasia, we have these two stages, low-grade dysplasia and high-grade dysplasia, with also here some papillary projections, and here there's a loss of, again, cell polarity, and nuclei are enlarged, and here you have the accompanying gene mutation involved, and here you see that SMAP4 is an early mutation. That was a late mutation in the Panin sequence, and here you have the KRAS as a kind of a late event. So we know these precursor lesions. If you are interested in the subject, I would urge you to read the article by Whitcomb that was published in Gastroenterology in 2015, a very nice overview, and he showed this graph. I think it's a very nice kind of way of summarizing the events that are involved in pancreatic cancer. It depends on whether you have an inherited cancer susceptibility gene, yes or no, and then there is the influence of different toxins and inflammation, and you get a mutation, a KRAS mutation, and depending on what happens, you can get silencing, for example, CDKN2A, and depending upon this phenomenon, if this then happens, then you can get this kind of event where you go into a Panin stage 3. This is an irreversible step. You get lots of growth genes, loss of DNA repair genes, and eventually, if there is an arise of a pancreatic cancer stem cell, you get division of pancreatic cancer cells, and eventually, because of progressive mutations, there will be one cell that is capable of causing a metastasis, and you have metastasized cancer. The question, of course, is what is the interval of all these events? Because if you talk about screening or surveillance, you need time to look and to find certain relevant changes in the architecture of the pancreas or in the metabolic processes. So what's the interval of progression of these phenomena? And I told you Withcombe is a very nice article, but this for sure is one of the nicest articles to read through if you're interested, because this is an article where they elaborately try to visualize and to calculate the timely events that occur in pancreatic cancer development. It all starts with one cell that has a mutation that has the capability eventually maybe to grow into a pancreatic cancer. If that happens, depends on subsequent mutations and cell divisions. Finally, if you have enough mutations of enough severity, there will be one cell that has that capability to grow into a pancreatic cancer cell. And then you get, again, cumulative progressive mutations, and depending on what happens, there will be one cell that has the capability to grow into a pancreatic cancer metastasis cell. And all these events have been calculated in a computer model based upon autopsy materials from patients with pancreatic cancer, where they took out not only the primary cancer, but also all the cancers from the sites of metastasis. And with some advanced statistical models, they could recalculate the time of events in all these steps. And it takes about 12 years to go to this first step of pancreatic carcinogenesis. It takes about 7 years to go through this step from pancreatic carcinogenesis into an infiltrating cancer. And it takes about 3 years to go from an infiltrating cancer into a metastasis. This is a huge time interval of 21 years. If only half is true, if only a quarter is true, that gives us all the opportunity to do screening in these patients, just as with colon carcinoma. Now, at present, what we do with surveillance, and that's also what we do in the Netherlands in a collaborative study, and we now survey over 300 persons, we use morphological imaging. We use EOS and MR. So we do both, and if there's no focal lesion or there's a stationary cyst without any worsened feature, we repeat investigations after 12 months. If we find a focal lesion, in the case we find a newly detected sidebench RPMN, we repeat follow-up after 6 months to see if it's stationary. And if there is anything that's worrisome, mass lesion or worrisome feature within, for example, IPMN, we have an expert panel and we have a consensus agreement, and we either decide to have an intensified follow-up or we go for resection. But this is morphological screening. I'm not going to allude to that too much because I'm sure that in the next talk you will be hearing more of that. What I want to look at and give you some kind of prospect of novel techniques and opportunities that are now being investigated to try to do good for these persons with high risk of pancreatic cancer. And there is still some prospects for imaging, and in particular metabolic imaging. Of course, blood is always very interesting to look at, and you can look at a lot of different things in blood. CA19.9, I think that's not very interesting, but circulating pancreas epithelial cells and cell-free nucleic acids have been reported. Of course, microRNAs, proteomics are being investigated. Saliva, very interestingly. MicroRNAs, microbiome to be tested. Stool, DNA, microbiome, and importantly, pancreatic juice. Again, CA19.9, P53, KRAS and mutants. I don't have the time to go into detail in every of this subject, but I have chosen 3 just to give you a glance of what's ongoing. Very interesting metabolic imaging. It has not been published yet. It's just accepted in Gut. It's going to be published soon, but you can read it already online. A group that looked into metabolic imaging with a C13 pyruvate MR spectroscopy. What did they do? This is an animal experiment. They had mice of a special breed, and these mice have the tendency, over time, very quickly, in months' time, to develop high-grade pancreatic lesions, so penin lesions and also pancreatic cancer. So if these mice are 2 months old, they have still 60% of ducts normal, but again, you see at 4 months' time, you see that low-grade dysplastic ducts rise from 40 to about 60%, and the high-grade lesions from almost 0 to 20, and eventually at 9 months, 0, 20, up to 50%. So a very fast progression model of ductal metaplasia and development of pancreatic cancer. And these mice were then scanned under an MR device, a spectroscopy device, and first given this C13 pyruvate. And interestingly, we know from other investigations that if you look at the lactate and alanine levels in cells, in particular pancreas cells, there is a relation between the level of metaplasia in these cells. And if you give these T13 pyruvate, that kind of competes and can bind to this alanine and lactate in these cells. So the amount of binding of the C13 pyruvate stands for the level of metaplasia, metaplastic cells in the pancreas. The higher the intensity, the lower the presence of metaplastic cells. And they have these all kinds of very complicated curves that they can calculate, and based upon the level and degree of histology, they have these higher shifts and higher curves of lactate and pyruvate levels. Now, where it all boils down to is that they are able to translate this into the intensity of the visualized C13 on MR spectroscopy. So in control mice, you see a very high intensity of binding of C13 pyruvate, whereas in a 9-month-old mice, you see a much lower binding of the C13 pyruvate. So after they scanned the mice, they sacrificed them, and they immediately took out the pancreas, homogenized the pancreas, and they looked for these levels, this ratio of alanine and lactate, and you see a very, very nice relationship between the age of the mice and the probability of having dysplastic cells and the level of this ratio. In the healthy mice, it's very high, and here in the high-grade dysplasia and in the mice with pancreatic cancer is very low. But this is, of course, an experiment. Here the mice were sacrificed, but this is the in vivo situation during actual scanning, and you see, not for all, but there is a nice relationship between the level and intensity of the spectroscopy with MR and the age of the mice, and thereby also the level and the numbers of metaplastic cells in the pancreas. Another example is the oral microbiome. James Farrell, a well-known scientist and researcher, also a lot of research done in the pancreas, looked at the oral microbiome. Very nice design, probe design, prospective specimen collection, had a discovery phase, verification phase, independent validation phase. And look here, if you look and you search and you compare between patients with pancreatic cancer and normals, and you look specifically at Neisseria elongata and Streptococcus mitis, you can get a very nice separation between patients with pancreatic cancer and normals. And if you draw a ROC curve of that, you can see that this is a quite nice graph with a sensitivity of 96% and a specificity of 82%. Immediately, if you then make the other comparison, and this is clinically very often a problem, and you take not normal persons, but you take patients with pancreatitis, there's a problem. You see immediately that the separation is not as nice as you can see with normals, and also the ROC curve and sensitivity and specificity goes down. But it's quite amazing to see that with something simple like taking some oral saliva and looking at the microbiome, you are able to make a distinction between pancreatic cancer patients and normals. Of course, it's not said that this can do anything about the surveillance of high-risk persons, but at least it's a technique that has been searched for to do early diagnosis of pancreatic cancer. And a last example is pancreatic juice analysis, because I told you what we do nowadays is we make an MR and we do EOS. And if you do EOS, you have to scan the pancreatic head, and if you scan the pancreatic head, you are in D2, you are in front of the ampulla. So then why not inject secretin, stimulate pancreatic juice outflow, and then just suck all the fluids that are secreted there at the level of D2 for 5 minutes and collect them in a separate tube. Because for sure, that fluid will consist of a lot of the ductal washout of the pancreas. Well, that was done, and GNAS mutations are quite specific for IPMN. They bear no relevance with regard to the grade of metaplasia, but they are indicative for the presence of IPMN. And look, they found GNAS mutations in 64% of persons with IPMN, both familial and sporadic cases. 45% had very small cysts, smaller than 5 millimeters. importantly, they had 57 controls, and there was no GNS mutation measured. So that seemed to be a quite sensitive marker for the presence of IPMN. That was kind of confirmed because they had subjects in whom they had serial pancreatic evaluations over time. And what was very interesting to see is that GNS mutations detected in baseline juice samples predicted the subsequent emergence of these IPMNs. So this could be something for the future to take in consideration. I told you that GNS is not indicative for the grade of metaplasia, but for example, KRAS is. So the same group tried to look at the relevance of determining KRAS mutations in pancreatic juice. And this was kind of disappointing maybe, because you can see in pancreatic cancer cases the prevalence of mutant KRAS is very high, but also in screened individuals without an obvious morphological tumor or relevant lesion, it is also very high, 50%. So what then should you do with these cases? If you don't see a morphological kind of identifiable lesion that you suspect of being pancreatic cancer, but you have this high relevant prevalence of KRAS mutation. So that doesn't seem to be of that much help, but at least it shows that from collections of secretin-stimulated pancreatic juice collections from the duodenum, we can do relevant gene analysis, and of course KRAS is only one gene. So to get to the end of my talk and conclusions, I think we are only at the beginning of exploring the possibilities and the prospect of pancreatic cancer surveillance. Currently, we use EOS and MR, and we are able to detect precursor lesions. We have lots of examples in my clinic of that. The problem is we don't know exactly sensitivity and specificity, and that's an issue so far. I showed you that there are additional techniques being explored and developed, and I think some of them are quite promising. But I think this is an important key message that should be stressed. By no means, we have proven that we're doing something good for these high-risk patients. We screen them and we give talks and we are very excited about all this, but we have not proven that we do anything good for these patients. We have not proven that we increase their life expectancy. And so the only sensible thing to do, I think, is to continue surveillance, but we should do that in collaboration. We should have collaborative prospective research studies, because that's the only way to get the good numbers to make final conclusions. And we should not forget to also collect tissue materials. Thank you very much.